Good afternoon, third year students of JPRSM Xavier University. I am Dr. Jana Joy Rivera Tusalem, your lecturer for today, and my topic is about vaginal hemorrhagic disorders in the second and third trimesters of pregnancy. It is often said that obstetrics is a bloody business. Thus, this afternoon, allow me to start my lecture by giving you cases you will often encounter in clinical practice. And so the first case is that of a 26-year-old G1P0 on her 34 3/7 weeks of gestation, computed by her last menstrual period, which is consistent with a singleton gestation and first trimester ultrasound. She came to the emergency room because of mild contractions for the last 2 hours that are increasing in frequency and intensity. She also endorses decreased fetal movement since the last onset of these contractions and had an episode of vaginal bleeding on arrival. She denies leakage of fluid or abdominal trauma. She has received scant prenatal checkup. Her initial vital signs are within normal limits, but she appears uncomfortable due to contractions. On physical examination, the heart and lungs are normal. Her abdomen is tender in all quadrants, and the uterus is hypertonic. She has a plasto-bilateral edema on both extremities. The nurse was unable to detect fetal heart rate by Doppler. Contractions are detected by tachometer, occurring every 2 to 3 minutes. On speculum examination, there is a golf-sized clot in the vault and active bleeding noted. Her cervix is 2 cm, cervical length is 1 cm, and station is -2 on digital examination. So now I'm showing to you how you're going to extract history and PE on an obstetric patient. Ultrasound is performed and there is no fetal cardiac activity detected. The placenta is located in the fundal area and there is no evidence of retroplacental clot. Amniotic fluid is normal and fetal biometry is consistent with the stated gestational age. Now, there are 3 questions that must be answered when you are confronted with this particular case. First, you have to know what are your differential diagnoses. What is your most likely diagnosis? And once you arrive at your diagnosis, you need to determine what should be involved in the management of this patient. With vaginal bleeding during the second and third trimester, one should consider 2 important clinical conditions, the placenta previa and abruptio placenta. In this case, there is bleeding associated with abdominal tenderness on all quadrants, and the perception of decreased fetal movements would point more to abruptio placenta. Now look at this slide, show a normal placenta in comparison to the placental abruption where you see a retroplacental clot as indicated by the yellow arrow. Now let's talk about abruptio placenta. What is abruptio placenta? It is a separation of the placenta from the site of implantation before delivery. Abruptio itself means rending asunder of the placenta, so it denotes sudden accident. Clinical bleeding insinuates between the membranes and the uterus, and when blood escapes through the cervix, it will manifest as external hemorrhage. But when blood is retained between the placenta and the uterus, it is now called concealed hemorrhage. So in this picture, you can see the difference between the 2 kinds of bleeding, the external bleeding as well as the concealed bleeding. Now, what is the etiopathogenesis of abruptio placenta? In abruptio placenta, there is hemorrhage into the decidua basalis. Now, the basalis would split, leaving a thin layer adherent to the myometrium. and so a decidual hematoma is developed. The hematoma will then expand and lead to separation, compression, and destruction of adjacent placenta. Now, what are the other causes of abruptio placenta? It would include an impaired trophoblastic invasion with subsequent atherosclerosis during preeclampsia. Inflammation and infection can be contributory, and in some instances there is rupture of spiral artery which will eventually cause a retroplacental hematoma. As the hematoma expands, it disrupts more vessels so that the uterus is unable to contract and in turn unable to compress torn blood vessel because of the presence of the products of conception. The escaping blood may dissect further between the membranes and the uterus. In some instances, there is effusion of blood behind the placenta, but its margins are still adherent to the uterine wall. When the membrane breaks, blood may gain access into the amniotic cavity, and sometimes it will cause leaking of the amniotic fluid that is admixed with blood into the vagina. With a fetal head closely applied to the lower segment, that blood cannot make its way past, and it will contribute more to the concealed hemorrhage. With increased pressure within the intervillous space caused by the expanding retroplacental clot, it forces more placental thromboplastin into the maternal circulation, which may lead to consumptive coagulopathy, a condition that you don't want to happen to your patient. Now, who are the patients that are at risk in having complications of abruptio placenta? Those with increasing age. From a faster trial, the first and second trimester evaluation of risk, the study revealed that women older than 40 years old were 2.3 times more likely to experience abruption compared to those 35 years or younger. Hypertension and preeclampsia, most frequent condition associated with abruption, and if you are chronic hypertensive with a superimposed preeclampsia or associated with fetal growth restriction, the risk is increased by sevenfold. With preterm premature rupture of membranes, there is sudden decompression during rupture and may cause separation of the placenta. The vascular disease caused by smoking confer 5 to 8-fold increase if associated with chronic hypertension. Cocaine abuse confer alarming increase. Uterine myomas, especially if located near the mucosal surface behind the placental implantation site. The other differential diagnosis, as mentioned earlier, is placenta previa. That is the bleeding with a live fetus. Sometimes we have painless vaginal bleeding, which may be accompanied by labor pains. So you should be able to identify that the contractions are that of labor pains or hypertonic uterine contractions of abruptio placenta. Sometimes fetal blood vessels cross or run near the internal os and could rupture and cause bleeding, and so you will have a condition called vasa previa. Usually, diagnosis of placental abruption is done by exclusion. With severe placental abruption, diagnosis can be obvious, but there is no diagnostic test that would confirm lesser degree of abruption. Intravascular coagulation is universal, and that is the reason why prompt diagnosis and management is of utmost importance in order to avoid this complication. Elevated levels of D-dimer can be found in these cases. Elevated levels of alpha-fetoprotein, more than 280 micrograms per deciliter, will have a 97% predictive value. So what are the complications of abruptio placenta? You have hypovolemic shock. Placental abruption may be complicated by massive and torrential bleeding. Prompt treatment with crystalloids and blood transfusion in order to reverse oliguria is very important. Usually you have consumptive coagulopathy or your disseminated intravascular coagulation where your plasminogen is activated to plasmin. Delay in recognizing hypovolemia due to hemorrhage can occur due to normal physiologic changes. Of course, your expansion of your blood volume during pregnancy. With blood loss, there is vasoconstriction, and thus we can maintain the perfusion to vital organs. So, the first symptoms or the first sign that you can see is compensatory tachycardia. Blood pressure usually at this time would remain stable until the blood loss exceeds 30%. The first vital sign to change is your heart rate, and that is the tachycardia, and the last to change is hypotension. Management of abruptio placenta is anchored on the following. Fluid and blood management should not be delayed until hypotension develops. Replace fluids early to prevent renal failure, and principles of resuscitation should be applied. So what are these principles of resuscitation? First, you have to open two large bore infusion lines. Insert your Foley catheter because urine output is an indicator of perfusion. Type and cross-match blood. Take your laboratories, your CBC, metabolic panel, your coagulation studies, especially your fibrinogen level. If, however, fibrinogen determination is not available, you can do a simple clot retraction test. What you do, you extract blood from the patient, and if clot does not form in 6 minutes and lyse in 30 minutes, that means your fibrinogen level is less than 150 milligrams per deciliter, and that should alert you of coagulopathy. Therefore, correction of anemia and coagulopathy should be in place. Now, how do you manage abruption? The approach in the management would vary depending upon the presentation, the gestational age, and the degree of maternal and fetal compromise. So if you have an abruption with a dead fetus, maternal stabilization is a priority. So you do close monitoring of hemorrhage and assessment of anemia and coagulopathy in order to determine the hemodynamic status of your patient. You should order for 4 units of blood, preferably your packed RBC, because blood loss of more than 50% in the presence of abruption is enough to kill the fetus, and thus vaginal delivery should be planned as long as maternal hemodynamic status is stable. So once stabilized, you can do induction or augmentation if initiated by oxytocin, prostaglandin, or mechanical dilators. Cesarean section is considered only if there is maternal hemodynamic instability or there is an obstetric contraindication to vaginal delivery. If you have a fetus that is alive or near term, delivery should be expedited. And if there is no spontaneous labor and the presentation is cephalic and there is no obstetric contraindication, induction or augmentation of labor should be initiated. If delivery does not occur within reasonable time and with ongoing hemorrhage, which is difficult to stabilize, cesarean section is recommended. Cesarean section is recommended when the fetal heart rate tracing is abnormal, and one should always be mindful that in the presence of DIC, cesarean section can be life-threatening. If you have a fetus that is alive at 24 to 34 weeks, maternal and fetal status is reassuring, then you go for conservative management. You just do close monitoring, give your antenatal steroids in order to enhance fetal lung maturity, and the patient and the family should be counseled that abruptio placenta is a very unpredictable condition and that normal testing can occur prior to catastrophic events. If the fetus is alive at 24 to 34 weeks, and if associated with preterm, PROM, preeclampsia, or intrauterine growth retardation, factored into the decision on whether to recommend expectant management versus delivery. The use of tocolytics is very controversial. If the fetus is alive and less than 24 weeks, the goal is towards conservative management to prolong the pregnancy and to improve fetal and neonatal outcome. Decision must be balanced with the risk to the mother. Consultation to fetal and maternal medicine should be done, and the wishes of the patient should always be respected. So what are some of the complications of your placenta abruption? You have your cuvillaire uterus or your uteroplacental apoplexy. There is widespread extravasation of blood into the uterine musculature and beneath the serosa. So you have here a violaceous uterus. Now these myometrial hemorrhages seldom cause atony and alone is not an indication for hysterectomy. Low levels of fibrinogen as measurable in the laboratory. If you can measure the fibrinogen fibrin degradation products or your D-dimer in the serum, sometimes it is accompanied by thrombocytopenia, and this poses problems during surgery because of bleeding. DIC is common with concealed hemorrhage because intrauterine pressure is higher, pushing more thromboplastin. Other complications would include end organ injury, or your acute kidney injury or acute renal failure. There is renal dysfunction from many causes. This is seen in severe abruption, and correction of hypovolemia is delayed. This is also magnified in the presence of preeclampsia. Another complication is Sheehan syndrome. There is anterior pituitary necrosis following severe hemorrhage. The woman at her early age can go into failure of lactation, amenorrhea, breast atrophy, loss of pubic and axillary hair, hypothyroidism, and of course your adrenal insufficiency. Okay, let's go now to our case 2. This is a 25-year-old G4P33003 at 19 weeks gestation by last menstrual period, presents for ultrasound appointment. The fetal anatomic survey is within normal limits, but a complete anterior placenta previa is noted. In addition, there is concern regarding thinning of the myometrium of the lower uterine segment. On-color Doppler shows a distance of approximately 1 millimeter between retroplacental vessels and that of the uterine serosa, your bladder interface. In addition, there is extensive intraplacental lakes that are noted, as indicated by your yellow arrow. So what is your impression or diagnosis in this case? So given the concern for a placenta accreta, you are contacted by the sonologist performing the ultrasound. You review the patient's obstetrical and surgical history. Of note, the patient had a history of 3 prior lower transverse cesarean deliveries. The first one was performed for arrest of active phase after an elective induction of labor at 39 weeks, and the next 2 were performed by a history of cesarean delivery. You have previously discussed with the patient contraceptive options, and the patient has told you that she may want another child, but is undecided. So you call the patient to discuss the result of ultrasound with her. What is your next step in evaluating the patient? Number one, counsel the patient about placenta previa accreta, the mortality and morbidity the condition entails, treat the anemia by blood transfusion, and planned hysterectomy and possible hysterectomy. Blood should readily be available. What is the potential maternal and fetal complication of placenta previa and accreta? Number one is hemorrhage, infection, risk is associated with blood transfusion. Hysterectomy, injury to the bowels, to the ureters, to the bladder, and the patient may end up in ICU or the patient may die. For the fetus, there is malpresentation, IUGR, and preterm birth issues. So as you can see, this is the normal placenta, the picture of a marginal placenta previa, and placenta accreta. So placenta previa in the internal os is if the internal os rather is covered partially or completely. In the past, we call it total or complete covering of internal os. It is partial placenta previa if the placenta partially covers the os, marginal placenta previa if the edge of the placenta is at the internal os, and low-lying placenta if placental edge does not reach the internal os and remains outside a 2 centimeter wide perimeter around the os. Sonographic findings of apparent movement of the placenta away from the internal os is a phenomenon called placental migration. It's not that the placenta migrates. However, it can be explained by this. This is related first to the imposition of the 2D or two-dimensional sonography. Second is that there is a differential growth of the lower and upper uterine segment as pregnancy progresses. There is greater uterine flow in the fundus, and placental growth is towards the fundus, and that is what you call as the trophotropism. Now, what are the risk factors that are associated with placenta previa? Usually they're basically the same as the abruptio placenta. You have your advancing age, multiparity, previous cesarean section, cigarette smoking, which causes hypoxemia, and then there is compensatory placental hypertrophy because of your defective vascularization due to inflammation. There is also elevated prenatal screening of the alpha-fetoprotein. There is increased risk for previa. So what are the clinical features of placenta previa? You have your painless hemorrhage, and usually they do not occur near or until near the end of the or after the second trimester. It usually occurs without warning. Initial bleeding should not be fatal, but reappear later in pregnancy. Low-lying placenta does not appear until labor ensues. Bleeding occurs during cervical dilatation. So low-lying placenta, the contractions of the torn blood vessels will occur so that bleeding may persist postpartum due to poor contractions. So how do you diagnose placenta previa? Transabdominal sonography is the simplest, most precise, and safest method of placental localization. TVS increases accuracy, but may be dangerous. Transperineal sonogram reveals inconclusive study. Internal exam should be done in a double setup, meaning that the patient should be in the operating room, and you do the IE, and once the patient bleeds or go into severe bleeding, you can immediately go into your cesarean section. But mind you, as interns, please do not do IE or internal exam when you have a patient who is bleeding suspected of placenta previa. Now, how do you manage placenta previa? Manage is dependent upon individual circumstances, depending upon the fetal age and maturity, the presence of labor, bleeding and its severity, and if bleeding is severe, cesarean section is resorted to in spite fetal maturity. Fetus who is preterm and no indication of delivery or no active bleeding, you do close observation, manage as outpatient, give your steroids for lung maturity. Usually you give your betamethasone 10 milligrams IM for 2 doses, 24 hours apart, or your dexamethasone 4 milligrams Q 12 hours for 4 doses. Advise the whole family to have all logistics ready 24/7 to transport patient to the hospital in case of bleeding. If the fetus is near term and no bleeding, schedule cesarean section. Now, the scheduling of the cesarean section will depend upon the society. The Society of Maternal and Fetal Medicine would say that you do the operation at the 34th or 37th week. Parkland would say 38th week. And NIH would say 34 to 35 weeks. Our author would say 36 weeks. Now, it would really depend upon your judgment. With severe hemorrhage, delivery should be done despite fetal immaturity. Cesarean section should be done on all placenta previa. Transverse uterine incision may be done with anterior placenta. However, usually vertical uterine incision is sometimes recommended. Now, if you have bleeding at the lower uterine segment and it is usually associated with accreta, it is managed as such. Sometimes you oversew the lower uterine segment. You have what we call the chew and call suture. You place a circular interrupted chromic suture. We don't have chromic now, so you can use your Vicryl below and above the incision, and then ligation of uterine vessels or your internal iliac artery ligation, and it should be removed after 12 hours. You do hysterectomy in cases when bleeding will not really stop. So here is a picture of your placenta accreta. As you can see that the placenta has invaded the whole of your myometrium. So let's go to the placenta accreta. The definition of placenta accreta is any placental implantation with abnormal firm adherence to myometrium because of partial or total absence of the decidua basalis and imperfect development of your fibrinoid or Nitabux layer. So you have your total placenta accreta if it's the entire placenta that is embedded into your in your uterus. It's partial if only several lobules are involved, and it is focal if only a single lobule is involved. Usually this is a histologic finding. So you bring your uterus and your placenta to the lab for examination. So what is the etiopathogenesis of placenta accreta? The cytotrophoblast may control decidual invasion through angiogenesis and growth expression. So your placental villi are now anchored to your muscle fibers rather than to the decidual cells. So here there is hyperinvasiveness. Usually there is a constitutional endometrial defect from a previous uterine trauma, especially from a previous uterine cesarean section scar. The placenta accreta indicates that the villi are attached to the myometrium. So here are some of the terms that you need to think about and you need to differentiate. Placenta increta, on the other hand, is invasion through the myometrium, and placenta percreta defines villi that penetrate through the myometrium or through the serosa. And this is usually a histopathologic diagnosis. Sometimes it will go beyond the uterus, it will involve your bladder, will involve the vessels and some of the intestines. So that is percreta. Now, placenta accreta is usually associated with previa, a prior cesarean delivery, and more likely a combination of two. There is decidual formation that is defective over a previous hysterotomy scar or follow any type of myometrial trauma such as curettage. So this history should be extracted. Diagnosis sometimes can be tricky. During the first and second trimester, there is hemorrhage, and sometimes it coexists with your placenta previa. Imaging modalities are less perfect. Sonography, the accuracy is only 65 to 92%. However, with color Doppler flow mapping, high predictive of myometrial invasion can now be given. And so how do you manage placenta accreta? There should be preoperative assessment and it should begin at the time of recognition. So you have to have a planned delivery in a tertiary hospital and it should involve multidisciplinary approach. Timing of delivery varies from different institutions and the clinical condition per se. The Society of Maternal and Fetal Medicine says that you should deliver at 34 to 37 weeks. In Parkland, it's 36 completed weeks. So cesarean delivery and hysterectomy. The risk of hysterectomy is expected. So therefore, you have to prepare the patient and her family, and you should be ready with blood. Bleeding will depend on immediate blood replacement. Uterine or internal iliac artery ligation may be done. Balloon occlusion or embolization can be done. Now, you can leave the placenta in situ if you have not suspected an accreta and that you are not prepared to do hysterectomy because you do not have blood. You can leave the placenta in situ and stabilize the patient and then go back when you are ready with all your logistics for your delivery. Now, one of the most feared complications of placenta accreta is your consumptive coagulopathy. A review of your second year pathology, you have this cascade of events that would lead to your disseminated intravascular coagulation. So you have here two pathways, the intrinsic and the extrinsic pathway. With tissue trauma, there is activation of your factor 7, which would activate your factor 10, which in turn would convert your prothrombin to thrombin. Please take note of the catalyst of each step. Thrombin will now be converted into your fibrinogen, your fibrinogen to fibrin, and thus the formation of your fibrin clot, your unstable clot. Now, the fibrin clot will now attract platelets and other phospholipids to make it stable. There is now consumption of all your platelets and coagulation factors, which will lead to massive bleeding. Consumptive coagulopathy, or the actual consumption of your procoagulants within the intravascular tree. There is usually delusional coagulation, thus you have massive bleeding or massive loss due to hemorrhage. So DIC begins with the release of your tissue factors by your pathological entities. It then promotes release of cytokines from your endothelium. There is now general endothelial activation and the activation of your coagulation. So here you have a pathological cycle of coagulation and fibrinolysis with decrease in your platelets. Thus you have your DIC. Now, what are the other obstetrical syndromes that can trigger DIC? As we have discussed earlier, you have your placental abruption where there is a release of your thromboplastin. Another condition is the embolization of your amniotic fluid and debris into the maternal circulation, causing activation of your factor 10. Other obstetric syndromes that can trigger DIC is the endotoxins by your gram-negative bacteria and the exotoxins by your gram-positive bacteria. So how do you diagnose DIC? Usually you can diagnose DIC or you have a high index of suspicion if there is excessive bleeding at the sites of modest trauma. For example, in venipuncture sites, nicks from your shaving perineum, trauma from your bladder catheterization. Sometimes you have spontaneous gum bleeding. There are petechia and purpura at the pressure sites of your BP cuff, and these are possible signs of your DIC. Now, your fibrinogen level, the normal value should be 300 to 600 milligrams per deciliter, and during DIC, it goes below 150 milligrams per deciliter. You have a serious hypofibrinogenemia if you have less than 50 milligrams per deciliter. Your D-dimer should be abnormally high, of course, and your platelet is very low. Your prothrombin also is very low. Now, the management for DIC is that the priority is to remove the inciting cause and the correction of your hypovolemia. There are comorbid conditions, the fetal death and delivery, so you have to do induction of your labor. If you have your amniotic fluid embolism, the labor should be expedited. Meconium stained amniotic fluid and the tears in your uterine and pelvic vessels should be corrected. Another complication that is grave in the course of an obstetric event is your amniotic fluid embolism. You will suspect that you are having an amniotic fluid embolism if you have a sudden or abrupt cardiopulmonary arrest and with both hypotension and respiratory compromise. Documentation of DIC is also present. The clinical onset is during labor or within 30 minutes of delivery. And in a patient who is previously has no fever, he's now having fever at 38 degrees centigrade. So what is now the pathophysiology of your amniotic fluid embolism? There is now a disruption of your fetal and maternal interface, and this is because of the entry of your fetal material into your maternal circulation. With that, there is then activation of your pro-inflammatory mediator system. Initial transient pulmonary vasoconstriction and hypertension will occur. There is now right ventricular infarction and your left-sided cardiac failure. Cardiogenic pulmonary edema and systemic hypotension will now occur with acute respiratory failure. Here you will have severe hypoxemia. Fetal material can now activate your factor 7 and would now initiate your cascades leading to your DIC. So how do you manage amniotic fluid embolism? There should be cardiopulmonary resuscitation and advanced cardiac life support. A suitable temperature at 36 degrees centigrade. There should be intubation. You give your inotropics, dobutamine, your vasopressors in order to treat your systemic hypotension and evaluate for coagulopathies and manage bleeding. And so a doctor attending to an obstetric patient should always be on his toes for any event that may come during the course of pregnancy. While it may give us joy to bring a life to this world, but it will also bring us sadness to see those who are supposed to bring life succumb to hemorrhage. And as we are facing this pandemic, I laud all of you for your courage of not giving up medical school. And soon when you are done, you can say with me, I gave up my life to learn how to save yours. Thank you for your attention.